today's presentation. Dr. Ellen Magaziner.
Thank you very much, Dan, for that wonderful introduction. Let me see. Okay. All right. So I'm not just technologically challenged. So I'm moving some things around here. I can see that. No. Yeah. Okay. All right. Well, thank you very much. And so today I'm going to give you an introduction to some of the things I've been doing over the last many, many years. And I started my practice, as Dan said, about 35 years ago, which is way before we even called it integrative and functional medicine. Back then, I think we called it complementary and alternative medicine. We called it CAM, and we still do at times, of course. But anyhow, so I'm going to introduce you to some of the things that I'm doing these days. And what happened was about 20 or 25 years ago, patients came to my office and kind of said to me, unfortunately, I was diagnosed with cancer. Can you help me out? And at that time, I didn't know what to do too much. And I wasn't taught this in medical school. And so 90% of what I'm going to talk about today, I was not taught in medical school, but I learned it afterwards. And many years ago, I started going to conferences. I found that there were many that I never knew existed on integrative oncology. And by the way, I need to stress the fact that I'm not an oncologist. I am board certified in family practice, as you mentioned. So what I'm going to talk about today is basically things that I'm introducing or adding to enhance our current therapies that our patients are receiving from their conventional doctors, their oncologists or radiation oncologists and surgeons, et cetera. So this is not in place of, it's in addition to, and I really want to make that point clear. So today I'm going to talk about, I can't talk about everything because it's too voluminous and there's not enough time here, but I'm going to talk about an introduction to what is integrative oncology and why we do it in the first place. I'll talk about some of the lab work that I'll touch on some of the lab work that we're looking at that goes beyond, I think, what most of us have been taught about. We're going to talk about very controversial therapy that more and more people are learning about, and it's intravenous vitamin C, followed by something that I never heard of until 15, 20 years ago, cancer stem cells. And then we'll talk also about something I started learning about maybe about 8 years ago called repurposed drugs, and it has to do with blocking the metabolic pathways of cancer. So this is not all-encompassing, but these are some of the areas that I've chosen to talk about today. I guess you can do that when you're in a lecture. So why do we get cancer in the first place? And most of you know this, but the leading two are at the top of this list here, and it's poor diet, nutrition, environmental chemicals. Those are probably two leading causes that may account for upwards to maybe 60 to 70% of all cancers, depending on who you read. And I'm not going to go into detail on either of these because you already know a lot of this, and hopefully the meeting even this past weekend may have touched on some of this. Other reasons include chronic infections, excessive stress. And I find it with my patients when I talk to them about the genesis of their cancer, we talk about when did it start, I find that close to 80% of the patients will say that they had some type of stressful situation in their life that may have been contributing factors perhaps. Obesity, genetics, excess alcohol intake, excess cigarette smoking, radon exposure, air pollution of varying sorts, medications, and there's various others that we're not going to talk about today. But these are some of the reasons why we get cancer. And we know now that cancer is almost an epidemic in this country. We're going through this epidemic with COVID right now, but unfortunately, about 1,600 people die every single day from cancer in this country. And it's not just last year or the year before. This has been ongoing now for many, many years. And so we really need to address it. And obviously, prevention first should be the most important thing. We're not truly going to discuss prevention today, but I strongly feel that's the number one treatment for cancer, to just prevent it in the first place. And unfortunately, it's impacting, every single one of us knows people that have had cancer or are fighting cancer. The latest statistics show that it's probably about 40% of all women will be diagnosed with cancer at some point in her life, and about 50% of all men at some point in his life. So we're somewhere around the 45% mark right now. That number may be expected to go up as well. So I feel we need to try to, number one, take a more integrative and innovative approach to, number one, prevention, but also when we have cancer, there's a lot of research going on now can we do more than just take out the tumor itself? Is that enough? And my answer is no, it's not quite enough. And I think we need to start addressing what's now being called the biological terrain or the microenvironment of the tumor itself. And we'll talk about some of these factors today. The microenvironment is gaining a lot of recognition today. And, just removing a tumor from let's pretend your hand or your breast or so, that's not going to get at what are some of the driving forces that may be contributing to the genesis of this tumor or the spreading of the progression and the metastasis of this cancer. And so that's where I think we need to develop, and what I'm working on is what can we do to, I just want to move the pictures over. What can we do to address the biological terrain of what's maybe contributing to the progression of these tumors so we can have a better outcome with our patients and enhance current therapies. So why do we need to support treatment in the first place? Well, we need to improve the overall current outcomes of our patients. We know that recurrences are occurring at too great of a number. We're seeing people that, let's say, had breast cancer, they go home after treatments, after a year, 2 years, whatever it might be. And then we hear about recurrences coming back. And this is happening too often, in my opinion. I see it in my practice. I would say at least 2/3, if not more, of the patients that I see in my practice who come in with cancer are coming in because of recurrences. Oh, I just lost hold on one second. Okay. Oh, shoot. Can you hear me still?
Yes, we hear you fine.
Yeah, we can hear you.
All right. So we want to take a proactive approach to reduce the leading cause of death in a cancer patient. And it's not always the tumor itself. And we're going to go over these leading causes in just a moment. We want to reduce the side effects from current therapies, and we know there are many for that. And I will show you a slide regarding that. And if we can reduce the side effects, we're going to improve the quality of life of our patients. And that's, to me, one of the most crucial things. Research for cancer, we spend a lot of time and energy looking at, did the patient live longer? But we don't spend as much time, or I think we don't spend enough time looking at the quality of life, and do we improve their quality of life so they can have a fruitful and productive life while they're receiving their treatments. We also want to increase the chances of remissions and extend their survival time and lifespan, and really meet the growing demand of the public. We're seeing more and more patients who are coming in saying, hey, can you help me out? I have cancer and I'm looking for something more. So I developed this, I call it my wellness, my supportive cancer therapies wheel here, and you can see it here, but we're not going to be able to discuss every one of these, but these are some of the things I address. I take a very holistic approach, looking at the whole person, not just the disease itself, and not just saying, we need to scan you and get PET and CAT scans. We need to look at the whole person, and we need to see what they're eating. What about their psychosocial environment? What about their stressors? What about exercise? And we need to target all of these different areas in order to have the highest chances of success. And we need to modulate what's known as, once again, the biological terrain, so it becomes unfavorable to cancer growth. We want to basically say to the cancer cells, we don't want you growing anymore, but at the same time, we want to strengthen and nourish the patient. One of the biggest problems with chemotherapy, it does a good job in killing cancer cells, but at the same time, it also destroys and disrupts normal healthy cells. And if we could find a chemotherapy that disrupts the growth of the cancer cell, but yet leaves the healthy cells intact, we'd be hitting a home run. So anyhow, one of the concepts of integrative oncology is the concept that cancer needs to be looked at or reviewed upon as a systemic disease. And so we know that excessive inflammation is one of the major driving forces for cancer. And most chronic degenerative diseases, by the way, of course, we know that heart disease, and you can go on and on and on with depression and sleeplessness and arthritis, et cetera, are all driven by inflammation, but so is cancer. And you can measure different inflammatory cells in a cancer patient that's generally heightened compared to a non-cancer patient. We also see that there's mitochondrial dysfunction in a cancer patient, in cancer cells. I should say a patient with cancer, not a cancer patient. That's not good verbiage. But also, there's work that's been done by Dr. Tom Seyfried from Boston University, has talked about cancer as a mitochondrial disease. So I do some assessment and treatment in hoping to assist the mitochondria in patients with cancer. We also see that there's tissue hypoxia in cancer cells, and we may need to address those as well, but that's interrelated to the mitochondrial issue as well. And there's significant immune dysfunction. And I've been measuring different immune cells, including things like the T and B cell lymphocytes, natural killer cells, inflammatory cytokines, inflammatory interleukins, and looking at these in our cancer patients and how we can best regulate and disrupt some of the inflammatory process and beneficially affect immune function. We need to address, obviously, their nutrition, lifestyle, their diet, their mind-body situation, their stressors, their detoxification pathways. All these things should be looked at when we're dealing with a patient with cancer to affect the best outcome. Wait, I'm trying to figure out. Here we go. Sorry about that. I am technologically challenged here. So we have a concept in integrative oncology called thriving while surviving. And we want to emphasize this point very much. We want the patient to thrive while they're surviving and undergoing their treatments. And we want to transform cancer from an acute disease into one that's more of a chronic illness and perhaps to be managed and lived with for many, many years and stabilized during their treatment phases. So cancer doesn't have to be an immediate death sentence. And it doesn't have people. I have some patients going on now for 10, 15, 20 years with their cancers. So we need to address these situations. I'm having trouble advancing my slide. 1 second. Okay. So our goal is to support our patients, and we want to improve their quality of life while they're undergoing their treatments. We want to reduce their side effects and complications. We want to increase their chances of a long and lengthy remission and improve survival time. And reduce recurrence is very, very important. I mentioned that I see a lot of breast cancer patients, and I would say that 2/3 of the ones who are seeing me, patients who are seeing me, are coming with recurrences. And once you have a recurrence, it's more and more difficult to treat because the cells have become resistant. The cancer cells are now resistant to some of the chemotherapies or radiation, whatever therapies that we're offering our patients. So we need to address this microenvironment. And this includes addressing these different factors that I have written here, ones that I've talked about. And not only inflammation in the immune system, but one of the biggest problems we see is blood clots. I've seen many patients who come in and tell me they had blood clots previously. And we'll talk about what we can do for that, because this is one of the things that leads to the demise of our patients. It's not always the tumor. It's the effect of the tumor that's having on our overall health and wellness and our overall systemic circulation. We're also trying to address the mitochondrial dysfunction. Cancer generally uses anaerobic metabolism. It ferments glucose or sugar for its main source of fuel, whereas healthy cells tend to use oxygen in an aerobic glycolysis and for its main source of fuel. So one of the things we're trying to do in our treatments is to try to change the overall metabolism of cancer cells from an anaerobic to an aerobic metabolism. And cancer cells tend to are low energy. They are generally a low energy state, and we want to bring it back to more of a positive, cancer cells are about -20 and -30 millivolts of energy, whereas healthy cells are somewhere around a -70 millivolts of energy. And we want to try to change the energy within our cancer cells to more of a healthy cell. And we have to address detoxification, especially if our patient has previously received chemotherapy, or even if not, if they're on various medications. We need to make sure the detox pathways are open, involving lymphatics, kidney, liver, and other parts of the body. All this is an effort to disrupt the metabolism of the cancer cells while leaving the healthy cells intact. And that's a crucial statement, I feel. So these, unfortunately, are the 5 leading causes of death in a cancer patient. Patients don't always die because there's a tumor sitting on their breast or their shoulder or their prostate or their lung. Unfortunately, metastasis is a leading cause of death in a cancer patient. And that is something that we try to address. How can we protect and prevent metastasis in a patient with cancer? I mentioned blood clots. This is something too that very, very common. It might be the second leading cause of death in cancer patients. It's in the top 5. Infections, things like peritonitis, pneumonias, etc. Can this be prevented? Cachexia, wasting. We know if patients lose their appetite, they don't want to eat anymore. And cachexia is a leading cause of death. And then, of course, end organ failure, such as liver, kidney, and heart failure. So part of what I believe in a support program that we've developed here is to try to protect our patients from these 5 leading causes of death. And I explained to my patient, you need to continue with your oncologist, your radiation oncologist, your surgeon, all your internists, all your doctors, but we are going to do our best to protect you from these 5 conditions. And we often find that our patients live a heck of a lot longer than what's typically expected by the medical literature when we utilize this concept. And so we take a deeper dive into their immune system, their inflammation, their metabolism. We look at various nutritional markers. We look at lifestyle factors. We look at gut health, and we look at environmental chemicals and other toxins exposures. There's a variety of different lab studies that can be done to address all of these factors. And when you're dealing with integrative and functional medicine, I feel that you need to take a deep dive and look at these factors to give our patients the best chance of healing and wellness. So let's take a little look. I'm only going to discuss 2 of these labs briefly today, but this list is some of the different lab work that we are doing in this practice. I won't say that we do every single one of these on every patient, but these are some of the different labs that I typically may look at at varying times. And we will track these labs in our patients to see, are they doing well? Are we making progress or not? And can we come up with different, are there going to be abnormalities before a tumor recurrence may even arise? And I believe that we can utilize some of these concepts to try to protect our patients from recurrences by using these kinds of ideas. Now, obviously, every one of us and every one of you uses the top line and, a CBC and a chemistry profile. But I'm going to say I don't feel that this is enough. And this is what's typically used in more conventional settings. When I talk to my patients and they tell me they just completed or are completing chemotherapy, for example, and I'll say to them, well, how is your doctor monitoring you from here on in? They say, well, he has me come back maybe every 3 months or so, and he does a blood test. And I, of course, ask them what kind of blood test. And they tell me they're doing a metabolic profile, a CBC. And I'm like, well, you didn't have an abnormal CBC or chem profile when you first were diagnosed. I don't think that that's going to be thorough enough and comprehensive enough to really see if something might be coming back. And so we're looking for early warning signs of disease before they even arise. So the first one I'm going to talk about, I'm only going to talk about briefly these first 2 that are highlighted in bold. But the first one, called galectin-3, I had never learned about, I never heard about in school. And hopefully some of you are learning about it because it's been associated with increasing, if it's high, it's associated with increasing risk of vascular disease, in particular congestive heart failure. And so you may have seen it, this galectin-3 on some of your lab tests for heart failure issues. But what you probably aren't aware of is that it's something that may fuel cancer growth and metastasis and also cause heart failure and cytokine storms and sepsis. So it's exactly the type of thing that we look at in all of our patients when I first screen a patient. And I will monitor this to see if we can drive it down. Now, we want to see the galectin-3 level below 17.9, at least in the lab that I'm using. Your labs could be slightly different. But ideal, so the difference between like normal range and what is ideal, at least that's how I look at things. So for a cancer patient, we do want this level to be below 14 and preferably towards 12. Because this protein in the bloodstream will contribute to a lot of cancer growth, metastasis, immune dysfunction, and also evades the immune system. It causes the cancer cells, to evade the immune system. So there's more research every year now on galectin-3 that's being done over the last 30, 40 years here, you can see. And this year, in the last year or 2, they expect over like 900 scientific papers to be published in the medical literature, just on galectin-3 and research for cancer and other chronic diseases. Generally speaking, the levels are generally higher in those with cancer, and especially those with breast, colon, and lung cancer, compared to a healthy control. And you can see a healthy control might be below 10, but the levels in a patient with cancer is much higher in general. And you can see on the left side of the screen, most of the tumors that are common cancers generally have higher levels of galectin-3. So once again, the utility of this is looking at this, and if it's high, seeing what we can do to bring it down to protect against inflammation, immune dysfunction, and also metastasis. It also drives high levels of this protein can drive angiogenesis, and we don't want angiogenesis to the cancer cells. So there's a lot of utility of using this. It's not, it generally will get covered by most insurances. And I will say that galectin-3 can be blocked. So here's a therapeutic pearl by various forms of what's called modified citrus pectin. That is a supplement that you can purchase in the health food store on your own. And I will say, I don't think I'll give a brand name specifically here because we're CME approved, but there's one in particular that has been found and shown, because they've studied it with evidence-based medicine, to be more effective than most other ones on the market. And this was, it's out there, and maybe in a question and answer session, if we're not CME approved, I can mention it to you. But keep this in mind, because it can, this protein can stimulate angiogenesis. It will evade the immune system and can cause metastasis and inflammation. And all these factors can, by blocking galectin-3, we can increase the survival of our cancer patients, hopefully, by reducing the metastasis, which I said is one of the leading causes of death in a cancer patient with cancer. The other protein or enzyme that I'm also often checking, you've all heard of this, but we only check it in conventional medicine typically when we suspect a blood clot has occurred, and it's called D-dimer. But what we have been doing is I've been checking this on every new patient that walks in the door for me, every cancer patient, because we see higher levels than normal in cancer patients. And so it's been associated with increasing, of clinical cancer stages and increasing risk of metastasis. Especially you see higher levels generally in breast cancer, colon, gastric, pancreatic, and rectal cancers compared to healthy controls. So my feeling is, rather than waiting for a person to have symptoms of a blood clot and then checking their D-dimer level, I check this on all my patients when they come initially to see me. We take a proactive approach rather than waiting and using more of a reactive approach with everything I do. So this is part of my initial panel. And so we're using various forms of enzymes called lumbrokinase and nattokinase when we see high levels of this enzyme, D-dimer. Obviously, you see higher levels in those with COVID, and those with sometimes with COVID vaccines may increase it as well. But we're looking at it in our cancer patients. So it has maybe a greater utility than certainly than I was taught in medical school. So we know the conventional therapies for cancer, of course, surgery, chemotherapy, radiation, and now the targeted immunotherapies. And what we're doing in our office, we're simply adding treatments to that foundational therapy. So these are some of the common side effects of chemotherapy, radiation. You've seen this in your practices, in your clinics, and we're here to reduce these side effects. And you'll see, especially the right side, where it mentions blood clots and low platelets and anemias and end organ failure. I do believe that we can reduce our risk in our patients developing these things, and also even the cachexia, the weight loss, the loss of appetite, fatigue, weakness, brain fog, very, very common side effects. And I think if we take a more proactive approach and utilize a support program, we can have better success. From a traditional chemotherapy radiation standpoint, there's also problems from a cellular level. They generally weaken the immune system. I mean, let's face it, does chemotherapy strengthen your immune system? No, it's going to weaken it some. So there's things we can try to do to strengthen the immune system. We can, these therapies also can increase inflammation. So chemotherapy actually increases cellular inflammation. And therefore, we use a lot of anti-inflammatories in my practice. Now, my practice, we try to use natural things whenever possible. So, you've all heard of things like curcumin and boswellia and green tea and maybe resveratrol. All these have some anti-inflammatory-like effects that block some of the different inflammatory pathways. Where we know that chemotherapy radiation can disrupt mitochondrial function and cause cancer cells to become resistant to future treatments. These therapies also can distort DNA. They suppress the p53 suppressor gene, and they can, of course, damage our end organs or organs such as liver, kidney, and heart. And most important, I'm going to bring up a new concept soon. We'll have some slides later on. These therapies can actually activate cancer stem cells. And these are cells that are very troublesome and troublesome that I'm hoping some of you have learned about, and if not, I'll introduce the concept today. So as a result of these different side effects that I just showed you, as a result of some of the recurrences that we're seeing today and patient dissatisfaction sometimes that occurs with cancer therapies, a lot of the physicians are now getting involved in using high-dose vitamin C. It's commonly used in, and this is intravenous vitamin C, in integrative oncology practices. And I'm going to show you the next several slides will deal with this, but there's more and more medical schools and universities now researching the use of high-dose vitamin C as a complementary therapy along with conventional treatments. So you might be familiar with the University of Iowa. It's doing several studies now on breast and lung and I think brain cancers. Cornell is doing various studies, and maybe Jefferson, I don't know. But various medical universities are now looking into the impact of adding vitamin C therapy intravenously to their oncology treatments. And it does seem to have a chemotherapeutic-like effect. It reduces a lot of the side effects and improves the quality of life. In a few minutes, I'll show you some scientific support for that, but I'm going to just talk in general right now about some of the things we're doing. And then as the talk goes on, I will show you some of the papers that support what I'm saying. So vitamin C in high doses started being used intravenously way back in the 40s by Dr. Fred Klenner. He was a family physician in North Carolina. And we didn't have antibiotics to the extent we have today all back then. So he and others, and Linus Pauling initially was one of the researchers, but Klenner started using IV vitamin C in high doses in patients with influenza and various viruses, acute viruses, chronic viruses. And he saw that there was some benefit from this. Obviously, the antibiotics came out in the 50s, steroids came out in the early 50s, and a lot of this kind of fell by the wayside, and people were not using the C that much. But there's been a reactivation or an interest in using it now. And when we talk about high-dose vitamin C, by the way, in my practice, or at least for my purposes, I usually think of it in greater than or at least 25 grams of vitamin C in a solution. And by the way, there's other cofactors in it that are frequently used as well. And we'll talk about some of the different dosing that I've used. Oral vitamin C, however, does not have the same effect as high-dose intravenous vitamin C. You cannot obtain the appropriate blood level in oral C as you can in intravenous C. Not enough of it is absorbed orally alone to have the therapeutic or chemotherapeutic-like effect that we are looking for. And Dr. Mark Levine at NIH and Q Chen, who's mentioned here in the bottom as a reference, she and Dr. Jeannie Driscoll is a very close friend of mine. They have all done various research to show that oral vitamin C and IV vitamin C absorption and utilization is quite different. So in order to obtain a chemotherapeutic-like effect of vitamin C, it has to be given intravenously. And the other thing you have to do, at least in my practice, we actually measure the levels in our patients to see that we achieved the level that we are looking for. And in the bloodstream, it's usually at least 300 to 350 milligrams per deciliter of ascorbic acid in the blood in order for it to have the chemotherapeutic-like effect that we are looking to obtain. Is vitamin C safe when given these high doses? I believe the answer is yes, and I will show you some literature that is supporting that now. There's this one in particular, but most of the time, vitamin C in high doses is very well tolerated. Can it be, localized phlebitis? It can be, but it's put into a solution so that it's going to be hypertonic. By the way, you do not want to use an isotonic solution because that'll cause hemolysis of your red cells. So, but in general, it's much better tolerated than I would have ever expected. Once again, this was not taught to me in medical school. And, when you hear doses, when you take by mouth, maybe people take a gram or 2 or 3 grams a day by mouth. And then when you hear of 25 grams and 50 grams intravenously, you're like, whoa, what's that going to do to me? Is that going to harm me? Most of the studies have shown that these doses will not harm. And it has to be used under the right circumstances, just like anything else in medicine and life. There's a special blood test that we check on every patient before we use vitamin C IV, and it's called a G6PD level. And if a patient is low in this enzyme, we cannot use high doses of vitamin C intravenously at all. And so you need to screen your patients. They need to have decent kidney function as well. So we, of course, we get a metabolic profile, but we do check the G6PD level as well. So when we give vitamin C intravenously, it's known as what's called a prodrug. Basically it's an inactive, it's not so active, but it becomes active in the body, and it forms a new drug. It actually forms hydrogen peroxide in the extracellular space. And this, they believe, is one of the major aspects of why and how it works. Now, surprisingly, it is actually, when given intravenously, not an antioxidant, and it's actually a pro-oxidant, and it actually does not conflict with conventional chemotherapy most of the time. Now, we don't give it the same week as chemotherapy. We kind of give it a different week. However, most of the time we've been thought that, or it's been thought to us that when we give IV vitamin C, we better not give that to a cancer patient. Why? Because we think incorrectly that it's an antioxidant and it's going to inhibit the ability of the chemotherapy to be effective. The fact is that's not true, and it's not accurate from a scientific standpoint, because vitamin C, when given IV, is a pro-oxidant and forms hydrogen peroxide and other peroxides in general in the extracellular space, and it can and should be used in conjunction with chemotherapy in order to protect our patients and give them the best quality of life. Once again, I give it a different week, and it's a whole protocol that we use. So there are various studies showing that it can reduce a number of the symptoms that patients may experience when they're receiving chemotherapy alone, such as fatigue, pain, insomnia, loss of appetite, constipation, nausea. And it can improve their overall quality of life, and improve their physical being, their emotional, their social well-being, and of course, cognition as well, which is very important. It can reduce this whole chemo brain that a lot of people experience, and they tell you they have brain fog. So once again, it becomes a prodrug. You get generation of hydrogen peroxide and other cofactors, and that and actually can strengthen the healthy cells but weaken the cancer cells. And so this, to me, is a perfect chemotherapy, or has a perfect chemotherapeutic-like effect. It's also anti-inflammatory. It also can activate some of the very important tumor suppressor genes, and it also has an anti-angiogenic effect to it as well. So I think we have to get out of our mindset that we can't give vitamin C when we're giving chemotherapy, albeit a different week, but it is safe, and I'll show you some more. It's effective and can be safe, and I'll show you some more studies that will bear that out. So is it safe? The answer is, generally speaking, they've done this in thousands of patients. I've probably given over 10,000 IV vitamin C high-dose treatments in the last 20, 30 years here. And by the way, if I could detract for one moment, when patients started coming to me and asked me about, what can I do for them for cancer, when I didn't know much at the beginning of my practice, I started seeking that out. How can I learn more? And I found that there were conferences, and to the point where I was going to 3 to 5 conferences a year before COVID, 3 to 5 conferences a year to learn more about the use of integrative and functional medicine with cancer patients. And my knowledge continually grew and grew and grew, because this is not something I was ever exposed to in medical school. And hopefully we're all getting exposed to it today. But yeah, so there are studies showing that in patients with lung cancer and brain cancers, that it's safe. It can be used in conjunction with everything that they're doing. And there's other therapy, there's other cancers too that it's been shown to be beneficial for. I have several patients who've had pancreatic cancer. We're using it in conjunction with their current therapies. Glioblastoma, I have several patients who are alive 3 and 4 years later. Now, unfortunately, this therapy doesn't, especially with these serious cancers, doesn't often and usually cure them, but it gives them a longer life. It gives them a better quality of life. We have several patients now 3 and 4 years out who have had cancer of pancreatic and GBMs. And my breast cancer patients, some of them are way beyond that time period as well. And so now, there's more and more research being done that we can mitigate the toxic side effects of chemotherapy with the use of this high-dose vitamin C. These are just some of the studies that bear this in mind, that once again, vitamin C is a prodrug. It's ascorbic acid that forms a steady state in the extracellular space, and it can be a foundation for a pro-oxidant treatment along with conventional therapies. All right, it'll help control the growth of tumors and modulate their immune system as well, and it can have a direct killing effect as well on the tumor and delay tumor growth in vitro, and its benefits that has been seen in vivo as well. This is a case report by my friend and colleague I mentioned briefly, Jeannie Driscoll, who, by the way, was running the integrative medicine department at University of Kansas. She has since retired. But anyhow, this is a patient that had pancreatic cancer, adenocarcinoma, which we know outcomes are generally very lousy. And this patient only received vitamin C IV twice a week for, I think it was a year or so. This patient, no, it was more than that. Anyhow, he lived for 4 years, just about 4 years, and unfortunately eventually passed away after he had a perforation of his intestinal tract and ran into sepsis and passed away. But this is an example of how this patient lived for just about 4 years just with vitamin C. And, because this disease, adenocarcinoma, is, associated with so many debilitating problems and just a problem. So anyhow, I'm not advocating just to do vitamin C alone. In this case, she did. The patient may have refused conventional therapy. I don't know the specifics. How much do we use? Well, I've used, afraid to tell you, but up to 125 grams in some of the patients, sometimes even more. We're looking for the amount that's necessary to bring the patient's blood level up to between 3 and 350, and sometimes up to 400 milligrams per deciliter of vitamin C levels, because that's once again where they found to have its greatest beneficial effect. We do not see much side effects at that dosage. Someone may see a little tired after treatments. They may be thirsty because it's hyperosmolar, hypertonic, but overall, our patients received it, have tolerated very well. I would say most common doses in my office are anywhere between 50 and 75 grams per treatment. And we do not see any liver or kidney dysfunction. We keep an eye on that quite carefully. In fact, those who've had liver enzyme elevation frequently due to chemotherapy, we see it beginning to come down. And by the way, vitamin C IV can be used for various forms of hepatitis too, because it does help kidney function quite a bit. This is a study where, the question always comes up, can you give chemotherapy and some of this and vitamin C IV alone together? And this was a study on pancreatic cancer, stage 4 pancreatic cancer, where they gave high-dose vitamin C twice a week to patients who were also receiving gemcitabine for pancreatic cancer. And then they took a look at these patients, measured the quality of life, chemistry profiles, and overall survival. Half the group received IVC with gemcitabine. The other half only received gemcitabine. They did not receive the vitamin C. And what they found is those who received both therapies together lived 2.5 times longer. Now, unfortunately, pancreatic cancer expected survival stage 4 from time of diagnosis, maybe 5, 6, 7 months. But those who received the vitamin C in conjunction with the gemcitabine lived 13 months, and they had a better quality of life with less side effects from the chemotherapy. I've had several patients who have GBMs, glioblastoma multiforme, and some of these patients are living 2 to 3 years longer than expected, which is exciting. Quality of life in those with breast cancer can be improved also. We're seeing that IVC has been able to reduce their side effects as well. And basically, I'm just showing you some of the different studies here that will support some of my earlier mentioning about things. Now, also with colon cancer frequently has been found to have various mutations, mainly the KRAS and BRAF genes. And there's some studies showing that ascorbic acid IV in high doses may actually reduce the effects of these mutations, and that patients are having better quality of life. So they're doing some more studies. This is preliminary. There's some now phase 2 trials that are starting on human solid tumors with lung, colon, and pancreatic tumors, see if they can confirm these initial results. So in conclusion, with the vitamin C section, we're going to go into two other things in enough time. One is, on vitamin C is that it can help destroy cancer cells while leaving the healthy cells intact. It is a pro-oxidant, not an antioxidant when given intravenously, and therefore can be used in conjunction with chemotherapy. I would do it on different weeks, however. And this is generality. I'm going to tell you that there's certain times that we may not give it in conjunction. We also, it reduces side effects and can work synergistically with chemoradiation. The next section I'm going to transition to is called cancer stem cells. And what the heck are those? Well, I never heard of these until maybe 10 years ago. And I started reading some of the work by a doctor. He's heading the oncology cancer stem cell research at University of Michigan, Dr. Max Wicha, W-I-C-H-A, if you want to look him up. And what they found now is that within a tumor, there are what's called circulating tumor cells, but a minority of these are known as cancer stem cells. And we've all heard of stem cells. From a positive standpoint, these are healthy stem cells. However, cancer stem cells are not something you want to have. These continually multiply and divide, do not know how to shut down, and they continually divide and multiply to the point where they're growing in an abnormal fashion. And we need to try to slow these down. Unfortunately, these are the cells, the cancer stem cells, that cause cancers to proliferate, to grow continuously, and to metastasize. And they also self-renew. And so they represent a small percentage of all the cancer cells in a tumor, but they exhibit, here's the key point, resistance to chemotherapy and radiation. They are not killed off by chemo and radiation at all. And so, in fact, chemotherapy and radiation may actually promote more of what's called stemness in the non-stem cancer cells. So those cells that were initially not cancer stem cells may become cancer stem cells because the chemotherapy can exacerbate this and make them even more irritated. It makes them more aggressive. And these are the cells, the cancer stem cells are the ones that cause recurrences. So I want you to keep that in mind. And we need to try to block these cancer stem cells. It is not easy. And there's no drug out there that, has 100% success of blocking these cancer stem cells. But these are the ones that we need to truly address. And I'm using a lot of botanicals to help in this cause. And we'll talk about some of those in just a moment. But there's accumulating evidence now that these cancer stem cells are the key drivers for tumor formation, progression, and recurrence. And I believe a successful therapy must include something to try to dampen these cancer stem cells because they are highly resistant to apoptosis and they're highly resistant to traditional chemoradiation. All right. So if you take a look at this is a diagram that basically is telling us that if you look at the center part and you just give a patient conventional cancer therapies, you may shrink the tumor, but the tumor may shrink later. The tumor may grow later on because you haven't addressed the cancer stem cells, which is the little cell here in the red. It's a CSC. And these are ones, once again, that may cause a recurrence. If you address both a combination of the cancer stem cells and conventional therapy, such as the bottom line here, the idea is that you will have a much better outcome in eliminating and or reducing the cancer growth. And I also want to say that, the gold standard in conventional therapy is to measure the tumor for your success or your lack of success. The problem is the tumor size is not always an indication of your success. That's hard to believe, but it's not, because if you have the center line here, a picture like that, you may dampen the size of the tumor with conventional therapy, but those cancer stem cells may go into hibernation and go hidden for a while, and then they come back with a vengeance. They come back and they're more aggressive, and they're now resistant to future chemotherapies. So you can be tumor-free, but it doesn't necessarily mean you are always cancer-free. So those two concepts are not equal. Cancer-free and tumor-free are not necessarily the same. The last part of this talk we'll focus briefly on what's called the care oncology protocol, or it's also known as the use of repurposed drugs. And I just call it the COC protocol. So I got exposed to this about 8 years ago. Never heard of this, and it blew my mind. I was at a conference, integrative medicine, integrative oncology conference, and a researcher, PhD, came and spoke for the hour. And he talked about the use of pharmaceutical agents and how it can reduce the risk of cancer recurrences and maybe slow the metabolism of cancer cells and block the fuel lines of cancer and starve the cancer and reduce what's called the metabolic drivers to the cancer cells. And just so you know, there's a book out if you want to read a little bit more about this, although I don't think the book is written in a way that it could be to be completely optimally helpful. The book is called How to Starve Cancer. It's sort of a layperson book by Jane McClellan, who's had ovarian cancer for about 22 years now, and she's doing quite well. She's had conventional therapy, but what happened, she's had various recurrences, and she decided she needs to see what else can be done. So she started delving into the medical literature and found that there's a lot of medicines, a lot of drugs out there that may be useful to slow down the metabolism of cancer and shut down the fuel lines. So these are 4 of the medications that I'm now using. And, one of the beauties about integrative medicine is we're integrating all types of therapies that are healthy for the patient or best for the patient without causing too many side effects. So originally, when I heard this talk, I was a little bit uncomfortable because truthfully, I don't use a lot of these drugs, or I hadn't been, but I am now in some of the more resistant cases, especially if there's recurrences. And not every single case is the same, by the way, but these are some things we're using. So these are 4, medications that are now what we call repurposed drugs. They're all FDA approved, but they're FDA approved for other purposes, not truly for cancer. So we're talking about metformin, atorvastatin, doxycycline, and even mebendazole, which is an anti-helminthic drug, a helminth, like parasite type of drug. But what they found now is these drugs may actually target the cancer stem cells, and they also work by other pathways to shut off the fuel lines to the cancer. So you can see here, this is an example how some of these medications may work in different pathways, whether it's the mTOR pathways, whether it's the GLUT1 pathways, the OXPHOS pathways, et cetera, in reducing the fuel lines, whether it's glucose, proteins, fatty acids, so we can slow down the growth of the cancer cells. The old drug called dipyramidol. Yeah, some of you who are maybe very young maybe not have heard of that one, but when I was in school, we learned about this as a platelet inhibitor, but they're showing too that may slow down the fatty acids and protein metabolism inside a cancer cell. But so we use a variety of these, and truthfully, there's many more than just these 4 or 5 or 6 shown on this slide. If you Google on your own, repurposed drugs in cancer, you're going to find many references, and I'll show you a few. So anyhow, these medications may block the pathways. We use these in combination frequently. However, they need to be rotated. There's a whole protocol that you'll learn about if you start delving into this. But these are very useful in sometimes achieving remissions in your more complicated patients. So there's a lot of literature out there about how statins may target some of the pathways in the cancer cells by inducing apoptosis and something called ferroptosis, which has to do with iron metabolism and lipid oxidation and lipid peroxides, which help go after the cancer cells. The whole idea is, once again, to target the tumor microenvironment, which is at the bottom there at 6 o'clock on the slide. And it also can regulate autophagy, which has to do with cellular repair. We know now, or at least research showing that vitamin C, along with doxycycline, may have an additive effect in slowing down this cancer stem cell propagation. And so by shutting down the glycolysis and by working on the OXPHOS pathways of the mitochondria. And, that's pretty fascinating. When I first heard this and learned this and started reading about it, I was like, this is mind-blowing. There's now more research or new research showing, too, that not only doxycycline and ascorbic and vitamin C may be useful as a combination, but maybe even adding azithromycin may also be a more potent combination to target the mitochondria and eradicate these cancer stem cells. I haven't often used the azithromycin yet, but something I'm going to consider. these few slides will just tell us that there's more and more research, breast cancer, and some of these repurposed drugs. There's a lot in regard to prostate cancer and these various repurposed drugs, and I just wanted to leave those for you. And even lastly, this mebendazole, which I'll show you right there, which I'd never used before in my life, but this too may have a beneficial effect in slowing down the progression of tumors and possibly even arrest some of tumor growth and help to reduce the metastatic spread of cancer and improve survival. So there's a lot of, I think we need to go with an open mind and see what can we do to truly help these patients, because I think that we need to do a whole lot more than what's currently done just with chemotherapy and not really talking to the patient about what they're eating and how sugar may feed tumor cells and what else can we do to benefit their quality of life and give them the longest chances of survival. Basically, we use a lot of natural agents in my practice. Everyone is individualized. It's not like everybody follows the same protocol. We utilize a lot of our past knowledge along with the patient's previous successes and failures. We utilize what the literature says, what our lab work is telling us and how it's guiding us, and our, of course, diagnosis and our tumor type as well. And so once again, in conclusion, our concept here with integrative oncology is to go beyond simply removing and reducing the size of the tumor. Let's work on the microenvironment and biological terrain. We want to reduce the overall oxidative stress in the body. We want to improve mitochondrial function in the body. We want to control inflammation, inhibit angiogenesis to the cancer cells, promote apoptosis, strengthen immunity, control blood sugar, and control the cancer stem cells, all with the idea of controlling and improving the microenvironment to change the course of the disease. We need to have an open mind with all these new possibilities. So with that, I hope I sparked your interest for some new ideas, and I'd be happy to entertain some questions if we have time.
We have time for a couple of questions. Anybody have a question for Dr. Magaziner?
Yeah, Dan. Dan?
Go ahead, Bernardo.
Thank you. Dr. Magaziner, pleased to meet you. We have shared a number of patients through the years. I'm Bernardo Marizaldi. And I was wondering if you have had any experience using homeopathics in the treatment of cancer patients. There are a few very prominent researchers that have been doing work on this, especially Farooq Master and Dr. Ramakrishnan, who have published textbooks on the treatment of cancer with homeopathy. I wonder if you have had any experience with it.
I'm well familiar with homeopathy, although I don't consider myself a homeopath. So, and I know that you do much more conventional homeopathy than I do. I have used some homeopathy in my practice. In fact, is this part CME? This question section?
You can answer this.
Okay. So I've used some homeopathic forms of mistletoe in my practice, and I think that Johns Hopkins is doing some research in that regard. So I've used various homeopathic remedies in my practice, but I don't consider myself a true homeopath. I don't have the background in that. It's more of a quote, I call it first aid, which is not to the level that a conventional homeopath would have. But I do use it. I didn't, a lot of what I use I didn't even mention because we don't have time, but I also use cannabis in my practice. I send people for it. I don't have it here, but so we use a lot of different tools. We use acupuncture, we use craniosacral therapy, we use all types of modalities in my practice. I have health coaches, so we do a lot of things here that I, haven't really talked about.
Beautiful. Thank you.
Thanks.
We have time for one more. Anybody else have a question for Dr. Magaziner?
Either they're all asleep, they know it all, or they don't want to know any of it.
Well, we do a lot of vitamin C at the Marcus Institute, so maybe they don't have as many questions. Oh, yes, Dr.
Looks
Hanley
like Nate has
is
a question.
our medical oncology. Dr. Nate Hanley is a medical oncologist here at Jefferson who has a question for you.
Hi, Dr. Magaziner. Yeah, so we have a couple of protocols looking at IV vitamin C in combination with chemotherapy, various chemotherapeutic agents. And so I'm curious what the frequency of the dosing that you use is. And we actually dose up to 1 gram per kilogram generally in those protocols. So Yeah. So the question is frequency. We usually give it twice weekly, actually.
Yeah, I usually do it twice a week as well. Very good. I don't think we know yet what is the optimal dosing. I will say that some of the studies that were done by Dr. Driscoll, for example, her studies on ovarian cancer were patients were treated twice a week. There's various studies now. Most of them are using twice a week. Part of it has to do with the convenience of the patient. How often can they get in here? But I don't think we know the full answer. And I think we don't know what the optimum dose and frequency for each different tumor type is either. Is it different ovarian versus breast versus prostate? I don't know that we know that, but I will say that we're all learning. And in my practice, we generally start off with twice a week for a while. So thank you. Mm-hmm.
The one comment I would make is that we do our studies with Dr. Levine at the NIH, and his idea is the more the better, because you get that high blood level from the infusion and within hours it's gone. And so optimally, he likes 3 to 4 times a week for most tumor types. So in the phase 1 pancreatic trial we did with him and published a few years back, we did 3 times a week and saw, very good results. On average, though, most patients could only make it in a couple times a week. So I think if you looked at the different, when we reported on how often they got the infusions, it was like 2.3 times per week, just because it was difficult for a lot of people to make it all 3 times. But that was the ideal or the goal based upon his animal research.
Yeah.
Dr. Magaziner, thank you for that terrific talk. We really enjoyed having you this morning. For those of you who are attending the next one, we'll give you a minute to log off and then back on again. But we really appreciated this for our grand rounds, and we look forward to interacting with you more, Dr. Magaziner.
Thank you, Dan. I appreciate inviting me. I appreciate it very much. Have a good day, everyone.